There it is.
Okay,
All right.
welcome to the October Talk with the Doc. Thank you, Dr. Leichliter. Thank you, everyone, for attending. And hand it off to the doctor.
It's hard to believe it's October already. Time's really flying. Well, welcome back, everybody, or if you're new, welcome to the party. I'm Dr. Leichliter, for those of you who don't know me. I'm a so-called movement disorder specialist here at Allegheny General Hospital, sitting in my office here on the north side, baking. My office is a little bit warm today. I do have a little bit of a cold. I swear I've been getting rid of this for like almost 2 weeks now. It's just not going away. So I got my tea on hand. I just had some cough drops, so I'm going to do my best. Couple of things that I usually throw out there ahead of time is that this is not a great individual therapy place. So, these are not questions that you should say, hey, what do you want me to do next? That's a great question for your doctor. These are usually general questions that might help everybody. The other caveat that I always tell people is that everything you hear is my opinion. I have a lot of opinions. Everybody has opinions. My opinion, I think, is based on as much fact and scientific knowledge as I can come up with, but you may go to a different neurologist or a different movement disorder specialist, and they may have different opinions. Take everything I say with a grain of salt. Most of the time, I speak from as much data as I can. If there's not a lot of data, I make it up. Because I can. And so if I'm making stuff up, I'll usually throw up some quotation marks and tell you that I'm making stuff up. With that being said, type your questions in the chat box. As Casey said, I will start with the ones that I got in emails, and then I'll go to the ones in the chat box. And again, as long as you guys keep having questions, I'll keep coming back and doing more question and answer sessions. All right. Well, the first one that I got in the email was kind of what is the maximum dosage of Cinemat? So carbidopa, levodopa is really our gold standard medicine for Parkinson's disease. And it was really what's the allowable or how much Cinemat dosage per day is recommended before Cinemat loses its effectiveness. Does it lose its effectiveness as Parkinson's progresses? And what are some of the options if and when Cinemat loses its effectiveness? And so there's a lot to that question. So levodopa is as close as we can get to replacing dopamine in your brain. And that was really the main chemical, not the only chemical, but the main chemical we think that really leads to Parkinson's disease. And it's pretty much the go-to drug for what we start first. There's been a lot of circle in terms of what medicine we start first. Should we hold off on giving you levodopa? Should we try other medicines first? But over the years, we've basically come full circle, and Cinemat is usually almost across the board the drug that we go to first. It gives us the best benefit for symptoms. It gives us the best impact on quality of life. Yes, it has problems. Yes, it has side effects. Yes, it has complications. But at the end of the day, it's still the best drug that we have. There really is no maximum dose of levodopa. Now, some pharmacies will have a maximum dose. Some insurance companies will have a limit. But realistically, you can go up as high as you want, as high as I want you to go. But obviously there's limitations in terms of problems, right? Side effects, dyskinesias or extra movements, hallucinations, fluctuations, sometimes just upset stomach, sometimes other types of side effects, but there's limits based on side effects. But I have some people that are on the equivalent of 2,000 plus milligrams of levodopa. Is that ideal? Probably not. Is it my favorite first choice? Probably not. But everybody's individualized. And for some patients, that is the best choice to ramp up their Cinemat for whatever reason. But you're right, it does lose effectiveness and it does cause problems. And it's both. It's partly the disease is progressing. So as the disease progresses, you need more and more medicine, but partly you get receptor changes. This is what leads to the fluctuations. This is what leads to the dyskinesias and the side effects of levodopa. And so there are complications that come. The higher the dose, the longer you're on it. We generally think 800 milligrams of levodopa is really where you start to develop dyskinesias or potential motor fluctuations. So we do try to keep it lower than that. But for any given patient, there's plenty of reasons to try pushing it higher. There really isn't a maximum dose, but we are limited by complications and side effects. And so that is, I think, kind of the answer to the question. The short answer is no. If you tolerate infinity milligrams of Cinemat, we could potentially get away with infinity milligrams of Cinemat, but it's probably not the best choice. Not my first choice, at least. So what are the other things we can do? Well, there's other medicines we add. We add medicines to help smooth out fluctuations. There's Mirapex or dopamine agonists. There's Comtan or COMT inhibitors. There's Azilect or MAO inhibitors. There's the anticholinergic medicines. There's amantadine. Then we start thinking about other things. When you start having problems with medicines, that's when we start thinking about deep brain stimulator surgery or duopa, which is the intestinal infusion, or high frequency ultrasound ablation, or these other techniques, often in conjunction with Cinemat, to see if we can get you doing better. And so the short answer to the question, or the really long answer to the question is there are other things you can do, and it really is individualized what the best treatment options are. Are low levels of potassium common in Parkinson's disease? I'd have to look that one up. I'm not entirely sure. That's not something that I run into a lot. I have a handful of patients that I know have chronic low potassium, who are on potassium supplements, who it's low every time they check. But I would say the vast majority of my patients do not have problems with electrolytes, with potassium, with sodium, things like that. Is there a correlation? I'm not entirely sure. Could there be a correlation with the medicines that we use to treat Parkinson's disease? It's always possible. But at the end of the day, what I would say is I do have some patients that have problems with chronically low potassium, but I wouldn't say it's common, and I definitely don't think it's the norm in people with Parkinson's disease. But that's also a great question for primary care doctors because they're better at potassium than I am. How can I know if I'm absorbing Cinemat tablets properly? Sometimes it seems like they don't make any difference. I'm taking 8 per day, and I schedule my meals around that to make the best possible time to take them on an empty stomach. Well, I mean, you sort of answered that question yourself. So, again, it's not uncommon for my patients to tell me, sometimes my medicines work really well and sometimes they don't work all that well. Sometimes it's related to food. So levodopa in particular is blocked by absorption with protein. So if you do take it with food or particularly high protein meals, it can definitely make your medicines less effective. But there's always a question of absorption, right? We know that there's a lot of stomach issues or gastrointestinal issues or small intestinal issues with Parkinson's disease. Gastric emptying is slow, so you don't release your pills into the small intestines very quickly. Um, Upper GI motility isn't very good. Colon motility isn't very good. Constipation is big. And so all of these things actually do impact absorption of the medicines. And the short answer is if your pills are working well, and then, sometimes they're not working well, those times you're probably not absorbing very well. The question is, what do you do about that? And that's a much more difficult question. And there's really no test for dopamine. You really can't take a blood test and measure what level you're at because there's not really good norm values, and it's not really that reliable. But you can tell that, hey, if I take my pills at noon and they don't seem to work very well, then maybe you're not absorbing them all that well at that time, and maybe we need to adjust the timing or adjust the dosing at that time. You're right to try to take it on an empty stomach. Usually it's a half an hour before you eat or an hour after you eat. But when you start taking medicines fairly frequently, then, it becomes a little bit tricky. I mean, I have patients that when they take the pills so often, they're like, when am I supposed to eat? Eating is important. And so these are all things that we have to consider and take into consideration when we're trying to figure out how to fix a problem like that. The absorption problem is difficult. There's nothing that really helps you absorb things a little bit better. And so you just have to work around eating, work around times where you're not doing as well, and do your best you can. But paying attention to when you eat, what time things work, what time things don't work, and then relaying that to your doctor or neurologist can at least help them adjust the medicines maybe around that time to see if they can smooth out those ups and downs. Can Exelon help with balance? Maybe. It's a short answer. So rivastigmine or Exelon is a Alzheimer's disease drug. It has been looked at in small studies in Parkinson's disease and walking imbalance. And at the end of the day, the data is iffy at best. Now, you may be my patient sitting out there and say, wait a second, you put me on an Exelon patch because you told me we were working on walking imbalance. And you're absolutely right, I did. I use Exelon not infrequently. Even though the data is iffy, there really aren't very good medicines that have good data for walking imbalance. They just don't exist, for better or for, actually, it's not for better, it's for worse. Believe me, I would much rather have good medicines for balance. but no medicine has really been all that effective in studies in terms of balance for Parkinson's disease or freezing of gait. So why do we even think about the Alzheimer's disease drug for Parkinson's disease? Because I do all the time. And that is a little bit more scientific. So when we typically think about Parkinson's disease, we typically think about dopamine, as I mentioned. We stained brains 60 plus years ago and found that the dopamine producing cells weren't there. There are plenty of pictures of this. You can see the pathology slides, but you just have to take my word for it. And this is the idea behind levodopa and most of the medicines that we use for Parkinson's disease. Most of the medicines that we use work on dopamine. But there's been some data that came out that suggested, well, perhaps the cerebellum, which is the back part of the brain that typically we think about in coordinated movement or balance, doesn't necessarily work as much on dopamine. It turns out it actually works a little bit more on acetylcholine. Acetylcholine is typically the medicine or the chemical that we think makes muscles contract. So in dystonia, I think a lot about acetylcholine. But in Parkinson's disease, we know it's not just dopamine. We know epinephrine and norepinephrine and also acetylcholine pathways are not functioning correctly. And so it's on the idea that perhaps if this acetylcholine pathway is not functioning correctly, maybe I can use a medicine for acetylcholine to see if we can work on that pathway and see if it will work on walking and balance. That was the idea of how we tried it and came up with that. Again, the data is iffy. It's not great, but there is some data to suggest maybe it helps. This is why I try it. I've had some people have some success with it. Doesn't work for everybody. There are definitely pros and cons to using medicines like this. But when we're dealing with balance, which is such an important problem because falls are such a dangerous problem, we have to use whatever I can find, whatever science I can grab a hold of and see if we can use it to our benefit. And so that's why you'll see me use medicines like Exelon. Sometimes I'll use Aricept. Sometimes I'll use Namenda. These are all the Alzheimer's disease drugs in my Parkinson's disease patients. Sometimes they help with memory too, but a lot of times I'm not using it in the typical Alzheimer's disease or memory pathway. I'm trying to fix the walking and balance. Does it actually work? Kind of iffy, but realistically, iffy is the best I have when it comes to balance. What does it mean when you have visual spatial issues associated with Parkinson's disease? It means you're not processing things correctly. And so a lot of my patients with Parkinson's disease have visual, spatial, or perceptual problems. I can't tell you how many times I hear, well, he grabs for something, he knocks it over all the time, or he can't seem to find something on the table sitting next to him, or this really becomes an issue when you're driving. You're trying to navigate a turn or trying to park. These are pretty common things that I hear all the time in the office. And it's really because the different lobes of your brain, mainly the parietal lobe and the occipital lobe, which deal with the visual pathways and the putting that visual information into some sort of organized format, don't work correctly. Again, we typically think about the basal ganglia, the deeper structures in Parkinson's disease, but Parkinson's disease is a whole brain problem. It is an all chemical problem. It is not just a problem here or a chemical here. It really does impact everything. Every system known to man is impacted in some way, shape, or form. And this is true for the visual kind of perceptual pathway as well. And that's in addition to the eye problems that we have. So a lot of my patients have blurry vision, double vision, eye movement problems. They can't track, so reading is very difficult. These are all things that I hear about fairly frequently and not uncommon in Parkinson's disease. Again, the downside to a lot of these issues is they're hard to fix. These are not things that typically respond to the dopaminergic medications, the carbidopa, levodopa, the Mirapex, so on and so forth. I send a lot of my patients to ophthalmology. I can't say I've ever had a tremendous amount of success sending people to ophthalmology. I have yet to find an ophthalmologist or a neuro-ophthalmologist who really has any earth-shattering kind of perception or ideas in Parkinson's disease, but never hurts to get the eyes looked at and make sure there isn't an eye problem or something that could be fixed. But at the end of the day, these vision problems, these spatial problems, these perceptual problems are really hard to fix, and you just have to kind of work around them the best you can. That's what I mean when you hear us talk about visual spatial issues, though. All right, a couple more in the email, and then I'll jump to the chat box. This is a good question. This is a great question. I hear this question all the time. At every talk that I give, I try to answer this question because it's really important. When making a diagnosis, what are the key features for each of the Parkinsonisms that help you distinguish them from Parkinson's disease? And so this gets to the question of what's the difference between Parkinson's disease and Parkinsonism? And this is a question I get all the time. And so it's worth answering. It's probably worth answering every time we talk. Parkinsonism is the combination of symptoms. So if you have a resting tremor and you have stiffness and cogwheel rigidity and you have slowness of movement, bradykinesia, and you have postural instability or balance problems, you have Parkinsonism, period. Parkinson's disease just happens to be the most common cause of Parkinsonism. So Parkinson's disease is when you have that constellation of symptoms and everything is typical. So typical age of onset, typical progression, typical response to medications, so on and so forth. If there's anything that's atypical, so either you're super young or super old, or you have symptoms that don't necessarily make sense, like you come to me falling first thing, which would be unusual in typical Parkinson's disease, or I give you medicine and nothing happens. These are all things that go against the typical progression or typical nature of Parkinson's disease. So I would call you Parkinsonism. There are a few other types of Parkinsonism. There's the Parkinson's plus conditions, which I'll get to in 1 second, which come with their own constellation of symptoms, which I'll talk about in 1 second. And then there's two other common named Parkinsonism. So there's vascular Parkinsonism and drug-induced Parkinsonism. So drug-induced Parkinsonism is probably the most common thing that I see. And these are people who are on dopamine blocking medicine. So any of the so-called antipsychotics, not just the old ones, Haldol, Thorazine, Stelazine, but also the second generation antipsychotics or bipolar medicines such as risperidone, olanzapine, which is Zyprexa, Geodon, Abilify, which is used everywhere, Rexulti, which is starting to get used a lot. All of these medicines block dopamine. And if you think about what blocking dopamine does, it looks exactly like not having enough dopamine, which is what gives you Parkinson's symptoms. There's a couple of nausea medicines, which are really Reglan and Compazine, which also block dopamine. And I've seen plenty of people that have been on those long term that can develop Parkinson's symptoms, stiffness, tremors, slowness of movement, balance problems. Those patients would not be called Parkinson's disease. They would be called medication or drug-induced Parkinsonism. Vascular Parkinsonism is when you come in and usually you present differently, which I'll tell you in a second. But when I look at an MRI scan, I see a lot of white matter changes or white spots on the imaging. And I show people this in the exam room. Everybody gets some white spots, some vascular changes as they age. But when I see a lot of them, or a lot of white spots surrounding the dark-filled, fluid-filled spaces in your brain, that's when I start thinking about, could it be vascular disease that is actually giving you Parkinson's symptoms? These patients usually present more with walking and balance problems, difficulty initiating gait, difficulty picking up their feet and making steps, but they usually do not have a lot of typical resting tremor and stiffness. They can, but not usually. And so that would again be a different thing. That's not Parkinson's disease, it's vascular Parkinsonism. And then there's a couple of Parkinson's plus conditions, and I'll run through them really quickly and just give you kind of the highlights because these aren't necessarily things that you have to think about all the time. There's progressive supranuclear palsy, which you'll hear us refer to as PSP. In PSP, people tend to fall. They fall a lot, they fall early, and they fall backwards. They also tend to have the difficulty or lose the ability to look up and down. They tend to be very stiff, and that's what tips us off towards PSP. Multiple systems atrophy, which used to be called Shy-Drager syndrome, comes with a lot of blood pressure fluctuations, orthostatic hypotension, to the point where they stand up and they pass out. Now, everybody here is going to say, wait a second, you told me I have Parkinson's disease and I have orthostatic hypotension. Orthostatic hypotension can be a part of Parkinson's disease, but it's not usually the first symptom. If you come to me before you're even diagnosed or early in your diagnosis with blood pressure problems and passing out, then I start thinking about things like that. If you've had Parkinson's disease for a few years and you're on some medicines, that's a whole different story. Cortical basal syndrome or cortical basal ganglionic degeneration typically presents with one side that's really, really rigid to the point where you lose control of it. So Parkinson's disease can also start on one side and be asymmetrical, which is not uncommon, but these people stay very, very asymmetrical to the point where one side's actually not bad at all, and the other side, they actually can't use it or lose control of it. And then Lewy body disease is the other Parkinson's plus condition, which comes with prominent visual hallucinations, usually early in the course of disease. So again, everybody here can have hallucinations with Parkinson's disease, but usually when people have early hallucinations, or preferably, not preferably, but most definitively diagnosed when you have hallucinations before I even put you on medicine, because we think it's the medications that lead to hallucinations in Parkinson's disease, where in Lewy body disease, it's the disease itself. So again, all of those things can look like Parkinson's disease. They would all be labeled as Parkinsonism because they can all present with tremors and stiffness and slowness of movement and balance problems, but none of them would be typical or classic idiopathic Parkinson's disease because they have some of these other or atypical findings or atypical things that go along with it. I am fairly strict on my use of the diagnosis of Parkinson's disease. There are probably a lot of people that come to me with Parkinson's disease who I currently have labeled with Parkinsonism. So if you're one of those people who goes and looks at your notes on my chart or your computer and you say, wait a second, Dr. Leichliter said I had Parkinsonism, I really reserve the diagnosis of Parkinson's disease for those typical people, typical age, typical presentation, typical response to medicine, typical everything. If there's anything atypical, or I haven't made the diagnosis yet, or I haven't given you medicines yet, or we haven't seen if the medicines work yet, I'll probably start with the diagnosis of Parkinsonism. And then if I think it becomes fairly typical, then I may change it to Parkinson's disease. That is probably not true if you go somewhere else. If you go to a general neurologist or a primary care doctor, they may take somebody with PSP and say this is Parkinson's disease. Again, no fault of their own. Again, this is something I do all day, every day, and they probably don't. And they probably have enough Parkinson's symptoms that that diagnosis makes sense. But if you're my patient or if you're coming to see me, I really do use a lot of the diagnosis of Parkinsonism until I'm fairly confident that somebody does have typical things and typical, everything that I expect. Not that it changes anything we do per se. I still use all the same medicines. I still harp on people about exercise. I still use all the therapies. But in my head, I like to have a distinction between people that have fairly typical disease and progression and people that I'm not quite sure about. That, in a very large and long nutshell, is the difference between Parkinson's disease and Parkinsonism. The interesting question is actually the follow-up question, which made me actually think about myself here. So the follow-up question was, is it common to change your diagnosis over time as patients' symptoms evolve and differentiate? And at first pass, I want to say, yeah, I do that all the time. But realistically, when I actually think about myself, no, doctors are not very good at changing their mind. Once we come up with an idea and once we have that idea in our head, it is really hard to change our mind that we're wrong. Again, not that I think I'm right. Well, of course I think I'm right all the time. But I'm probably pretty sure I've been wrong occasionally. But retrospectively or introspectively, I am not all that good and flexible at changing my diagnosis. Now, if the caveat to that is Parkinsonism. If I label somebody with Parkinsonism, I will go back and change that to Parkinson's disease or one of the other named ones. But interestingly enough, I almost never go the other way. If I label somebody with Parkinson's disease, I almost never, unless something really out of nowhere hits me, I almost never go back and say, maybe this isn't typical Parkinson's disease. Maybe this is one of the other conditions. And I know this about myself. Other doctors or other neurologists may be more flexible. It's just probably a bad habit of mine where I really don't question my prior diagnoses all that much. If somebody came to me and said, hey, question this diagnosis, I'm not sure you were right, then I'd probably think about it. It's not that I'm against doing it. It's just that once I've already come up with an idea of what I think's going on, it's really hard for me to then mentally shift and go back and change what I thought. Now, again, I like to think that more often than not, I'm right the first time. But I imagine there are definitely some patients, and I can think of a couple offhand where I've been wrong. Now, I've labeled them with Parkinson's disease only to find out later that it was something else. It was Lewy body disease or something different. And it really, not that I think I missed something, but I think it is a little bit of inflexibility in my brain of going back and changing my initial thought that keeps me from doing that. Now, again, at this point, it's not terribly vital or terribly important that I am definitive or specific with what I call it. And the reason for that is I don't have any cures and I don't have any disease modifying therapies. So I can get away with being wrong or I can get away with not being as specific as I need to potentially be. For instance, calling somebody Parkinsonism and not Parkinson's disease. However, I hope that we have a time where I do have precision medicine, I do have disease modifying therapies, I do have cures or things that alter the course, in which case I'm going to have to be more definitive and more specific and more accurate in my diagnoses so that I don't miss opportunities to really help people. Again, that's something I'm going to have to work on. But we're not there yet, but I'm hopeful that at some point we will get that. And then I will have to rethink and change my diagnoses from time to time. But I thought that was a really interesting question. I'm glad you sent that in because it does make me think about my own thoughts, my own brain, my own practice. And again, I should probably do that a little bit more, which hopefully moving forward I will try, but I make no promises. The one last question that was an email that Casey told me about was about the use of propranolol. Somebody had sent a question in, which she didn't send me an email, but she told me before we got on here, was that they have a friend who was on propranolol to help their tremors. Now, it's not an uncommon thing, particularly for people who are going to primary care doctors or other neurologists. Propranolol is traditionally or typically an essential tremor medicine. So the difference between essential tremor and Parkinson's disease in terms of the tremor is when you have it. So people with Parkinson's disease classically and traditionally shake when they're just sitting there. It's a resting tremor. It happens when they're just doing nothing. People with essential tremor classically and traditionally shake with activity. They're pouring a cup of coffee, they're eating soup with a spoon, they're writing their name. Now, we've also learned over the years that those two overlap all the time. Essential tremor can actually have some resting component to it. Parkinson's disease can definitely have some action tremor component to it. I don't know that I would use propranolol for the resting tremor, although I've seen it tried. Again, PCPs are much more comfortable using propranolol diagnosing people with essential tremor than they are at telling people they have Parkinson's disease, so I've seen it. But it just doesn't work all that well for that resting tremor. But it is pretty good for the essential tremor, the action tremor component. So if you're somebody who does have a little bit of a mixed type of tremor, it's actually not an unreasonable idea to use an action tremor type medicine, such as propranolol, to help calm down tremor. I don't think it would do a whole lot for the other Parkinson's type symptoms, but that would be a time where I might use it if I have somebody with a little bit of a mixed tremor. And believe it or not, mixed tremor is actually really not that uncommon. All right, moving on to chat box questions. Actually, let me take a step back because there were two questions that I didn't answer from the last time. So one was about a laser treatment that they were doing in other countries. And I tried to look that up, and the only laser treatment I could find in Mexico and Spain, which is, I think, what was written there, was the high-frequency ultrasound ablation, which we're actually doing in this country. So high-frequency ultrasound ablation is approved for tremor-predominant Parkinsonism, or Parkinson's disease, I'm sorry. I haven't used it a tremendous amount. In fact, I think I've only sent like 1 or 2 patients for evaluation, mainly because I don't have one in Pittsburgh. We don't have one here at Allegheny. They don't have one over at UPMC. The closest people that have the high frequency ultrasound ablation technology is West Virginia University and Cleveland Clinic, which is where I send my patients to. But I haven't used it or don't have a lot of experience with it in Parkinson's disease. I have a little bit more experience in essential tremor. That is basically where through ultrasound and MRI guidance, they can burn a small hole in the brain. We learned a long time ago that if you put a hole in a certain area of the brain, you can stop people from having tremors. That was the only laser treatment I could find. So if there is another laser being out there used or looked into, be more specific and I'll look it up. But that was the only thing I could find easily through looking. The other was the Evolutionary Healing Project. And I did look that up. I don't know I don't really know what to say about it in all honesty. The idea that they're using is kind of sound frequency treatment. And so I'm going to kind of overview this as best I can, but I'm not sure I entirely understand it myself. So a lot of this is kind of my interpretation of what I read briefly on their website, which is basically you listen to this audio session every day, and it's supposedly at this certain frequency of 10 hertz, which then resets your brain to this frequency, which is what helps people do better. Now, I thought about this for a little bit. And before I just wrote it off and said that's nonsense, it turns out when you do EEG readings, So as a neurologist, I can read EEGs. We do EEGs in seizures, epilepsy. You can actually see seizures and epileptic tendencies on an EEG, which is basically they put electrodes on your brain and they measure your brain waves. It turns out the dominant posterior background rhythm is around 10 in normal people. And so I would argue that maybe there is some science here that they're trying to get to the correct frequency. They're trying to reset to a normal frequency pattern. The caveat to that is I have to assume that people with Parkinson's disease, if I slapped an EEG on you, you would probably also have a normal posterior dominant background rhythm. I don't think that necessarily would be disrupted in people with Parkinson's disease. We know there's circuitry problems in people with Parkinson's disease, particularly in the basal ganglia. We can measure this with the deep brain stimulator. You're supposed to be firing at a certain frequency and you don't. But I don't think that also goes along to the dominant posterior background rhythm, at least not that I've seen. And so at the end of the day, if that's really what's being reset with this sound therapy, I'm not really sure it's going to be all that beneficial. Although, again, I'm always eager to see research, see things come out, see new things show up, especially things that aren't more medicine. And so more to come on that. I think if they come out with more publications, or if I see something in journals, I'll definitely let you know or keep you updated. But that was my idea or kind of thoughts on the healing project. Was that, again, I think it's too soon to tell. I need to see some kind of hard, fast evidence in human trials. I think there is maybe some science there that makes a lot of sense, but at the same time, I'm not sure. All right, those were the questions from last time that I didn't answer. And so now I'll go on to the ones from this time and we'll go from there. I'll try to not lose my voice. Are swollen ankles and feet associated with Parkinson's disease? Kind of. So especially if you're not up walking around a lot, if you're in a chair, you're, seated position most of the day, your ankles are going to swell. That's why everybody says get up and move around for people who do have swelling. But interestingly enough, and so probably not necessarily as a direct cause from the disease, maybe from some disability if you're not getting up and walking around, but definitely also as a side effect of medicines. So predominantly the two that come to mind the most are Mirapex and amantadine. Both of those I have seen significant swelling from. Both of those have swelling as a listed side effect, so this is not surprising, but I've seen significant swelling from both of those medicines. And so probably where I would start would be look at the medicines you're taking. It's usually more a side effect of medicine than it is side effect of disease. All right. Can I talk about focused ultrasound? Well, I can talk about anything. Is it effective and what are my thoughts? So focused ultrasound, just to backtrack a little bit, 100 years ago, we learned that if you put a hole in somebody's brain, you can work on their tremor. Michael J. Fox had this done, actually, believe it or not the high frequency ultrasound ablation, but he had the old version where they would drill a hole, they'd put a probe into your brain, they'd either freeze a hole or burn a hole, then they take the probe out. I'm pretty sure he had one. I think he mentioned that in one of his books. And so we've been putting holes in people's brains for 100 years. It was actually when we were putting holes in people's brains that they learned, hey, if I stimulate, that also works. And that's how we came up with the deep brain stimulator, which once we started doing deep brain stimulator surgeries, the idea for an ablation relatively went away. The ablations sort of went away because they were actually very prominent before carbidopa levodopa was invented. And so once we had a drug that really worked pretty well, the use of the old-fashioned techniques and the more invasive things sort of went away, but they didn't go away completely. Fast forward a little bit, we learned that we could also do the same thing with Gamma Knife without having to drill a hole in somebody's brain. Fast forward until probably 6 or 7 years ago, we learned we can also do it with ultrasound. And so ultrasound, the high frequency ultrasound ablation or the focused ultrasound is really putting you in an MRI scanner and then watching the tissue heat up as we aim ultrasound beams at a certain area of the brain until we burn a hole in the brain and then we stop. And that is fairly effective for tremor. It's approved for tremor predominant Parkinson's disease. I know it's okay or fairly good for tremor, but I question its benefit for the other symptoms of Parkinson's disease. For a while, it was not approved for both sides. You could only do one side. I think it may be approved for both sides, but you still have to do one side. And then I think 6 months later, you can go back and do the other side. I have used it on a handful of occasions for essential tremor with fairly good success. I would say for the most part, people have done well. I did have one patient who had the high frequency ultrasound ablation. I saw her a month after, her tremor was gone. I saw her 6 months later, her tremor was back. Now that's the only one patient that I've had where her tremor came back. The other patients that I've had, really, it did do fairly good. But again, I don't think I've sent too many Parkinson's disease patients for it because I question how much it's beneficial for the other symptoms. I think as we do more of it, as we start looking at other targets, then maybe we can start impacting some of the other conditions or other symptoms that might come along with Parkinson's disease, and you may see more use of it. It would also be nice if I had one here in Pittsburgh that I could play with and get to use a little bit more of, but they won't buy me one, at least not yet. I keep asking. But at the end of the day, my jury is still out on its effectiveness for Parkinson's disease. I think it's okay or fairly good for a certain subsegment of people for essential tremor. Yeah, but I haven't quite figured out how I'm going to use it in my Parkinson's disease patients. It may be worthwhile for somebody who really does have tremor predominant symptoms and they're not a great deep brain stimulator candidate for whatever reason. That's probably the person that I would be interested or start thinking about ultrasound ablation. But again, more to come as I see more of it and as I get more experience with it. And I guess address again how close to eating we should take the meds. So again, at the end of the day, it's levodopa that's the biggest problem. So it turns out the carrier protein that carries levodopa across the stomach and into the blood and into the blood-brain barrier to the brain is the same carrier protein that picks up large amino acids, i.e. protein. And so if you do, and the hard part here is I have plenty of patients that can take their pills with a steak dinner and they still work. And I have some patients that they take their pills and even like sniff peanut butter and it doesn't work. And so at the end of the day, it's genetic. How much of this carrier protein you have is genetic. And I don't have a test for that. If you have a ton of this carrier protein, then you can eat with your pills and they'll still work. If you only have a very few amount of this carrier protein, that's where you're going to run into problems. And so generally, I tell people a half hour before they eat, take your pills, or an hour after you eat, take your pills. But that is a whole lot of trial and error. You really have to try and see. Not everybody notices if they eat with their pills, they don't work. Some people, say, hey, I can take my pills 10 minutes before I eat. Some people have to take their pills an hour before they eat, hour afterwards. It really is a lot of trial and error. And there really isn't a good way to figure that out outside of trying it and see what happens. And so even though those are kind of rules of thumb or ballpark numbers, your best bet is to really just see what happens. Take it with some food. If it doesn't work, okay, you're protein or you're food sensitive. Try it a half hour before, try it an hour after. Still doesn't work, then you got to move it further away. But again, you can see how hard it can get, particularly for people who are taking frequent dosages of medicines. It becomes a problem when you're trying to squeeze in eating. Well, I'm glad your husband is doing well on Exelon. I do have patients who do well on it. This is why you will see me use it not infrequently. Today I drove to the end of the street and forgot where I was going. Is this Parkinson's related? I feel like I've done that actually. So that is a tough question. Probably is the short answer. You can definitely get forgetfulness. You can definitely get cognitive problems. You can definitely get memory problems with Parkinson's disease. However, you can get memory problems without Parkinson's disease. I don't think I have Parkinson's disease, and I've done stuff like that. Every single patient that I see, as they age, tell me they have senior moments. They walk into a room, they forgot what they were going for. They forget names, they forget people's faces, or so on and so forth. And so how much of this is Parkinson's disease? How much of this is typical aging? How much of this is some other illness, such as a dementing illness on top of it? We're not really that sure. Is it easy to just say, yes, that's probably related to Parkinson's disease? Sure. But again, if that becomes more of a problem, if you start forgetting more and more where you're going, if you start getting lost, if you start forgetting more things, these are all really important things that you got to bring up to your doctor. You got to bring up to your neurologist. You got to bring up to me. Not that we have great medicines for memory problems, but we at least need to keep an eye on it. And that might be something worth trying an Exelon or an Aricept for to see if we can help. So I'm not entirely sure if it's Parkinson's related. It's very easy to chalk everything up to Parkinson's disease. So the short answer is sure. But it's definitely something to keep an eye on and pay attention to. Voice is going down. Got to try harder. Husband has a bad time at 3 o'clock every day. We've done everything told to do. More ideas. This is interesting. So the vast majority of my patients have a downtime in the afternoon, anywhere from 2 to 5, or afternoon, early evening. And when I was a fellow, I trained under Dr. Baser, who I probably just took her word for gospel. I never actually fact checked her. But I remember her telling patients that this is a downtime for making dopamine for everybody, even those of us without Parkinson's disease. And so when I thought about that, I was like, well, that makes sense. If everybody makes less dopamine around this time, this afternoon time period, people who are already dopamine deficient are going to feel it more. They're going to suffer. They're going to be down. They're going to be off. They're going to be tired. They're going to be fatigued. And again, I never actually looked up if that was fact. That could very well be made up. But I can tell you time and time again, I hear this story. Afternoon time, I need to take a nap. My afternoon pills, my lunchtime pills are not as effective as my morning or evening pills. Again, I don't know if it's because that's a natural time to make not enough dopamine or if it's something else, but at the end of the day, that's actually a common thing. I have yet to figure out a solution for it. One thing I've tried to sell is, hey, that's a great time to go for a walk. Great time to go exercise, because exercise is the one thing that I've come across that consistently gives people energy. Now, again, you don't feel good at that time and you're tired at that time, so it's not exactly an easy sell. But that would probably be my first choice. How can we get you doing better at that time? Alternative, we start thinking about adjusting medicines, right? I give more medicine at that time. You just don't schedule things at that time. You take a nap at that time. There's a lot of different strategies for it. I can't say any of them are necessarily good, but everybody has to find a way to work on that time. All I can tell you is that is a very consistent and common complaint or problem that I hear about in my patients. I think it's just something you have to work around, and keep trying different things to see if you can do it. If you're not going anywhere or doing anything, take a nap. The problem is when you have things scheduled in the afternoon, then it's a little bit trickier, and then you start adjusting medicines. You try to figure out things like that. But that is a tough difficulty or tough problem to work on. Should any precautions be taken before surgery? I like the second part of that, communication with surgeon and movement disorder. Have you ever seen doctors communicate? Me neither. Doctors suck at communicating. Part of it is we're really busy. Part of it is we don't have a lot of time. Part of it is we get patients crammed into every free spot we do have for a variety of reasons. But doctors are really bad at calling each other. We're really bad at picking up the phone and saying, "Hey, I got your patient. This is what's going on here." So I wouldn't bank on communication between your surgeon and movement disorder specialist. Be nice, but I wouldn't bank on it. The things I usually tell my patients before surgery are make sure you take your medicines. Even though a lot of surgery will say nothing after midnight or, nothing from the day before it, that usually does not pertain to your medicines. Check with your surgeon, but 9 times out of 10 or 99 times out of 100, you should be taking your pills up until time of surgery. The last thing they want is a frozen person on their operating table, or particularly after they want you to wake up from their operation. And so I strongly suggest you talk to your surgeon. If they really are telling you to not take your pills, definitely ask them questions and definitely contact your neurologist. Because I would say the vast majority of surgeons and surgeries do not require you to stop your medications a day or so before surgery. You should really be taking your medicines up to surgery, and you should even bring your pills with you because again, if you're one of my patients or if you're on some of this newer stuff, don't bank on the hospital having it. If you're on Ryteria, if you're on Nupro patch, if you're on, Norians, if you're on some of these medicines, there is a very low chance that they're going to have that when you wake up. Take your pills with you. The other things are really aimed at your surgery and anesthesia team, which believe me, they know this stuff. Anesthesiologists spend a lot of time learning about different conditions and what medicines do. Surgeons there are so many people out there with Parkinson's disease. I would be surprised if a surgeon says, I've never operated on somebody with Parkinson's disease. We know just historically that anesthesia is not great for the brain. And so the general things that I tell my patients or the surgeons or the anesthesia team is as less anesthesia as possible. If they can get away with a spinal block or a local block, great. As little pain medicines as possible. And probably the most important, as quickly to get you back on your feet and up moving as possible. Those are generally the things that I tell surgeons or anesthesiologists or patients before surgery. Again, the less downtime, the better. The less anesthesia, the better. These are all the same things that are good for the brain. Those would be the things that, if you're my patient, I would communicate to the surgeon. But really, I think the key take home message is your medications. Make sure you're taking your medicines and take them with you when you go to the operation. I still wonder if the Abilify that my husband took for a year caused his Parkinson. I mean, it's always possible. So Abilify or aripiprazole is a second generation antipsychotic. And even though it works on serotonin as well, it does have some dopamine blocking properties. And when I give talks, so I'm a speaker for Ingrezza, which is a tardive dyskinesia drug. When I give talks, and usually it's to psychiatrists, neurologists about this drug, I usually do tell people that Abilify is actually the #1 drug in my experience that causes tardive dyskinesia, drug-induced Parkinsonism. Not because it's a bad drug. Abilify is a great drug. Abilify is a great mood stabilizer. It's a great severe antidepressant. It's a great bipolar drug. It's a great schizophrenia drug. The reason why I see so much side effect of Abilify is because it's prescribed so much. It's a sheer numbers game. Haldol, Thorazine, Stelazine, Risperidol, Zyprexa, Geodon probably cause more drug-induced or movement disorders than Abilify does. But Abilify is used so much, so frequently, so commonly that's why I see it so much. Abilify is a great drug. I have no problems with Abilify, but I do see the side effects of Abilify. And so the short answer to your question is it's possible. There's no good way to know. At the end of the day, I really don't treat those patients much different than I treat my typical Parkinson's disease patients. The drugs are still the same. The therapies are still the same. The exercise requirements are still the same. Everything I do, which is really just symptomatic management, is still the same. And so you can make an argument that it doesn't actually matter if it's typical Parkinson's disease or drug-induced or whatever, although I recognize that people really do like to know what's causing their problems. But when it comes to treatment strategies, it's actually not much different. What do I think about the SIN1 test for CND Life Sciences? I'm told it's a skin biopsy that is used to diagnose Parkinson's disease and its variations under Parkinsonism. So I've seen that where they're doing skin biopsies, fibroblast biopsies, they're doing some cheek biopsies. And then there's the alpha-synuclein test that came out of the Michael J. Fox Foundation. And there's a lot of these so-called biomarkers that are coming out. And I think they all have merit. I think there is some reasonable, use of all of these things. I'm not sure how commercially available any of them are. I recently looked into the spinal tap one that was really the CSF fluid, the alpha-synuclein one through the Michael J. Fox Foundation, and I couldn't get it. I wonder how good these are. I actually just had somebody contact me about tears. That's another way that they're going to start looking at these types of diagnoses. I mean, I think they're all interesting. And I think they're all useful at some point. I question how well they differentiate Parkinson's disease from some of the Parkinsonisms, although I know there's some suggestion that they could. The biggest downside, the biggest problem right now is that these are all really going to be useful first in research. They're all going to be useful in terms of grouping people. When you're testing new therapies, maybe you only do it in a subset of people who have a skin biopsy suggestive of Parkinson's disease. And what that's going to do is really advance the field in terms of precision medicine, which is what we need. We need to know specific underlying marked diseases or genetic diseases, and we need specific treatments that work for them. That's the definition of precision medicine. The problem is let's say I sent my patient, John Smith comes into the office and I say, oh, you have Parkinson's disease. He says, great. How do you know? Let's do a test. And I say, okay, let's go get a skin biomarker. Comes back as Parkinson's disease. All right, now I'm going to do the same thing I was going to do before we sent you for that test, but hope it didn't hurt too much. I've never had a skin biopsy, so I don't actually know how much they hurt. But at the end of the day, none of these tests actually impact anything I do just yet. And this is the frustrating thing in my world, which is, again, I anticipate, so that's the optimistic me. I anticipate that there will be a day where I do need these tests, and I do have to send you for a marker, and I do have to figure out what specifically you have so I know the best way to treat you. Today's not that day. And so at the end of the day, that's when things like that are going to be really helpful. When I have specific treatments, when I have precision medicine, that's when I'm going to need markers. That's when I'm going to need tests. And so all of these things are good, but I think right now they're mainly useful in the research field and not in day-to-day practice. Is surgery dangerous for people? I mean, I wouldn't volunteer. I wouldn't volunteer either, though. But if you need surgery, you need surgery, period. End of story. This is what I tell my patients, like, oh, I need a hip replacement, but what about general anesthesia? I'm like, look, I don't want to be the bearer of bad news, but they're not just going to give you a shot of whiskey and a stick to bite. It doesn't work that way. If you need surgery, you need anesthesia. And if you need surgery, you need surgery. I don't care if you have Parkinson's disease or not. It's my job to work around the end result of whatever it is you need. I would not want you to hold off on surgery or something that's going to help you do better or help you move better or move more or exercise, which I want you to do because you have Parkinson's disease. In fact, I want you to do it so you can get back to exercising and doing all the stuff that I want you to do. Is it dangerous? Well, dangerous is a caveat, right? It can definitely make your symptoms worse. Yes, I've seen that. It can make you need more medicine. I've seen that too. But at the end of the day, we're always weighing out risks and benefits. I would not want you to have surgery just for fun. There better be a darn good reason that you're having a surgery. But assuming that there's a darn good reason that you're having a surgery, I'm all for it if that's what it takes to get you doing better and heading in the right direction. And it's just something that we will have to work around in terms of the aftermath to figure out how to get you doing better again. And that's actually a really interesting question, Christine. Are there differences in the behaviors of insurance companies in Parkinson's disease versus Parkinsonism? Yes and no. So historically there were, and not necessarily in terms of medicines. And realistically, I'm not going to say I lie, but I may have stretched the truth in my day. I once had I don't remember if it was a drug rep, if it was a doctor, I forget who it was that talked to me, and I said, oh, this sounds like a great idea, but how do I get it for my MSA patients? And they said, what's the difference between multiple systems atrophy and Parkinson's disease with severe autonomic problems? And I said, not a whole lot. So I guess it's all in what you call it. And so the short answer is I have historically played a lot of games with insurance companies in terms of my diagnostic wording or what I call things. I never lie. Don't get me wrong. I'm not here to lie to people. I just may have stretched the truth. But actually, where I learned that it's actually probably not that much different is the VA. So before, particularly for Agent Orange, they would cover Parkinson's disease, but they were not reimbursing Parkinsonism. Now they are. They actually don't distinguish between Parkinson's disease and Parkinsonism. They can still get their whatever the VA gives for people who are exposed to Agent Orange for that. And so that's what tells me that there probably isn't much difference in the diagnosis between what's covered and what isn't. How many patients do I see in a day who are newly diagnosed with Parkinson's disease? Where do I send them for good information? Well, you're already there. Sites, books, blogs, podcasts. So I see, we'll just say on average about 20 patients a day. I think today I saw 19. I would say 2 of them were I don't want to say new diagnoses, but they were coming to me for the diagnosis of Parkinson's disease. So 2 out of 20. So maybe 1 a day, maybe 1 every other day. I don't know. I get sent a lot of people. I send them to the Parkinson's Foundation of Western Pennsylvania, which you guys are all already obviously associated with. If they're online people, I send them to the Michael J. Fox Foundation website because I think that actually has the most comprehensive information. Also has a list of all the research studies going on. I'll recommend Michael J. Fox's book because I think he gives a pretty good story as to how his went, and I feel like that's pretty relatable. So those kind of things are usually where I'll send people to. And then again, Christine, Casey, they have all these other places that they can send you to. So getting hooked up with support groups and things like that, that's usually where people end up. If diagnosed with Parkinson's disease but symptoms match Parkinsonism, is there a specific testing to delineate which is the correct diagnosis? And the short answer is no. All of the diagnoses that I rattled off earlier are are clinical diagnoses. So these are all diagnoses made in the clinic, in the office, based on symptoms. You could argue that maybe a DAT scan, which is a dopamine transporter scan, would be positive in Parkinson's disease and maybe not theoretically some of the other ones. But I can tell you, I've seen patients with some of the Parkinson's plus conditions that have positive DAT scans, so I don't think that's reliable. There's been a lot of talk about a lot of different markers. Neurofilament light chain is probably the one that shows up in every neurodegenerative condition known to man to try to distinguish normal from abnormal. And it's just not all that useful in day-to-day practice. And so the very short answer to your question is there is no test to differentiate these things. I am the test. And so if I tell you this is what I think, then I hopefully I can back up why I think that. And so even if you think that maybe there's a Parkinsonism and not true Parkinson's disease, there really isn't a good way to know that for sure. It's really based on how you progress, what changes, how you respond to treatment. And coming down back down to the second part of that question, would that change treatment? Not usually. The only time it changes treatment is if there's something else that we have to work on. So in Lewy body disease, I really have to get the hallucinations doing better. In MSA, I really have to work on the blood pressure. In PSPS, and tons of people for therapy because falling is their biggest problem. In vascular Parkinsonism, tons of physical therapy because gait initiation is really the thing. And so not that any of the medicines that I do is different. I still use carbidopa, levodopa first. I still use all the other medicines, but the other things that we have to work on change the treatment. But even then, as long as you're forthful and upfront with what's going on and what the symptoms are that are bothering you, doesn't really matter what I call it. I'm still going to work on it. Maybe. So if your main issue is not tremors, but rather stuttered type walking, is that more of an ism? Maybe. I mean, again, I would probably label that as a Parkinsonism. But if you go back historically and look at research on Parkinson's disease, when they tried to cluster people, there was always the tremor predominant Parkinson's disease, and then the akinetic rigid Parkinson's disease. And that was looking at true Parkinson's disease, or so we thought. So there are a subset of people with Parkinson's disease that do not have tremors and stiffness. They have the or more stiffness and walking problems. And that doesn't mean it's not typical Parkinson's disease. But again, in my very narrow view of what I label as, classic Parkinson's disease, I like to see the tremor, I like to see the typical symptoms, and I like to see the response to medicine. Does that make you an ism? Maybe. It may just be that you have a different variant of Parkinson's disease. But again, we also know that Parkinson's disease isn't one thing, and that's probably why there's so much variability. Should Parkinson's disease people get the RSV vaccine? I mean, I don't know. Are you supposed to get the RSV vaccine? I'm not entirely sure. Probably. I will answer that question with saying I don't think there's any contraindication to getting the RSV vaccine when you have Parkinson's disease. I'm honestly not sure who's supposed to get Parkinson's disease. I'm not a very good primary care doctor. This sounds like something they should know and they should talk to you about. But if my usual thought is if the primary care doctor thinks you should get a vaccine for something, I do not think Parkinson's disease should make you not get it. Can Parkinson's medicines conflict with psych meds? Well, it depends. Sometimes. So if you're just on the antidepressants, which I use in a lot of my patients, these typically work on norepinephrine and serotonin. Versus dopamine. But if you're on the more heavy duty medicines, if you're on the dopamine blockers, then yeah, all of the medicines that I'm giving patients for Parkinson's disease that increase dopamine are going to basically do the exact opposite of all the medicines that block dopamine. And so this is a game where we have to kind of pick and choose what we're aiming for, and there can definitely be some sort of interaction. How many more questions we got? There's a few. I'll answer them, and just don't add any more to the end. Otherwise, Christine's going to kick me off. Is there a benefit to the virtual training with Parkinson's? If so, is there a way to get the training? I don't know. I don't have a lot of experience with it. I know it's written about. I don't know how you get it is the answer to your second part of your question. And so because I don't know how you get it, I really haven't been able to have patients get it or do it and then come back and tell me. So too soon to tell. I mean, I know there's things written out there about it, the benefits of people with Parkinson's disease and virtual reality, virtual training, using virtual reality and physical therapy. This is a big, kind of area of research these days. But I don't know where you get it or how you get it. So I don't think I've had any patients do it just yet. And so I'm not really sure. We know several folks using Exelon that haven't noticed any change with cognition, but have noted improvement in balance. Yeah, I can comment on anything. And all right, so that's my last question. I'll end on this one. I think I can explain that. And so the reason is again, I use Exelon, which is a cholinesterase inhibitor. So what that means is it prevents the breakdown of acetylcholine. It keeps acetylcholine around longer in the brain. Since I think the cerebellar pathways, the balance pathways, are acetylcholine driven, keeping acetylcholine around longer should help those pathways work better and work on balance. That's why I use it in balance. In dementia or in memory, it's different. I don't quite understand. I'm not a dementia specialist. I have two partners who specialize in dementia because they're smarter than I am. In dementia, so take Alzheimer's disease, for instance, these medicines have not really been shown to improve memory. What they have been shown to do, or statistically do, is keep you at the level that you're at longer or slow down the decline. The problem with these drugs is exactly that. So I use them in all of my dementia patients, my Alzheimer's patients, and 10 times out of 10, people come back and say it's not working. And I say, well, how do you know it's not working? And they say, because I'm not remembering any better than I did before. And I said, well, that's because they don't do that. The goal of these medicines is to kind of keep you at the level that you're at. That is impossible to measure in any one person. I can do a study and I can give 500 people the medicine and 500 people not get the medicine. And I can say, look, the people who got the medicine tended to stay better longer than the people who didn't get the medicine. But you really can't test that in any one person. And so I hear a lot of times, well, this didn't improve my memory. And I say, well, I'm not surprised by that. Statistically, it doesn't do that. And we think that it keeps you at the level that you're on. I still use it to try to improve memory, but they're really not all that good for that. The goal of them in memory is to try to keep you at the level that you're at or slow down the decline, as opposed to help you think better. Again, I still try it because I'm hoping that we can get some success, but I wouldn't be surprised if they haven't noticed any change in cognition, but it has helped in balance because we're talking about two different pathways and two different things. And so that's how I would answer that question and comment on that. And with that, I will stop talking and pass it back to Casey and let her take it.
Okay, thank you, Dr. Licklider, as always.